Welcome back guys. After discussing about the proximal convoluted tubule, now let's discuss about the loop of Henle. Now look at this diagram. Guys, here is the proximal convoluted tubule. Now this proximal convoluted tubule is continuing as this loop of Henle. Okay, here is the loop of Henle. Now the loop of Henle is divided into descending limb of loop of Henle. See, here is the descending limb of loop of Henle. There is a hairpin turn and there is ascending limb of loop of Henle. So now tell me, there is mainly descending limb as well as ascending limb. Now look here, the ascending limb of loop of Henle is further divided into two parts. There is a thin part at the bottom and thick part here. Okay, above there is thick part, below there is thin part. Done. Now what else you need to know here is, see, the loop of Henle, it is present in the medulla. In the cortex, see here in the cortex there is a proximal convoluted tubule as well as a DCT and DCT. But where exactly is this loop of Henle present? The loop of Henle is mainly present in the medulla region. Done. Now what are the important points that you should know? See, when the urine is going through the descending limb of loop of Henle, what will happen? See, water is getting reabsorbed. Okay, who is getting reabsorbed? Water. Because there is medullary hyperosmolality. See, all in this area. Okay, there is medullary hyperosmolality. Okay, let me write here. In the cortex, what is the osmolality, guys? The osmolality in the cortex, the God made the cortex in such a way, the osmolality in the cortex is 300. But when you are going deep into the medulla, do you know what will happen to the osmolality? Osmolality increases 300, 400, 600, 800, 1000, 1200. So almost the osmolality in the medulla will be 1200. Okay, there will be medullary hyperosmolality. As you go deep down into the medulla, the osmolality increases. Now, what law of osmosis teaches us? Wherever there is high osmolality, water will go there. Okay, water will always go from low to high osmolality. So now, you all know the osmolality of the urine in the PCT. The osmolality of the urine in the PCT is 300. So now, when this urine is going through the descending limb of loop of Henle, because of the medullary hyperosmolality, what this medullary hyperosmolality will do? That medullary hyperosmolality, the sodium which is present in the medulla. Okay, here all hyperosmolality is there, right? The osmolality is because of the sodium. That hyperosmolality will help in absorption of water. So gradually look, water is getting reabsorbed into the medulla. Okay, the medullary hyperosmolality is absorbing this water, right? Now, where do you think this water will go? Now this water will be again reabsorbed back into the vasa recta, into the blood. Okay, the water is going into the blood. So what I am trying to say, the descending limb of loop of Henle, what it is doing? It is helping in water reabsorption. It's only permeable to water. Any solutes are getting reabsorbed. Any sodium, chloride, potassium, magnesium, anything is getting reabsorbed in the descending limb of loop of Henle? No. Answer is no. So only permeable to solvent but impermeable to solutes. Next, see, as the urine is going through the descending limb of loop of Henle, what is happening? Urine is getting diluted or concentrated? Say 600, 800, 1000, 1200. So urine is becoming hyperosmolar. Urine is becoming concentrated. So that's why the descending limb of loop of Henle is called as a concentrating segment. Done. So look at all these important points one by one. Descending limb, only permeable to solvent, that is water. Impermeable to solutes, no ions are getting reabsorbed. It's called as a concentrating segment of the nephron because the urine is getting concentrated. Done. So with this, successfully what we have completed? We have completed the descending limb of loop of Henle. Now let's look at the ascending limb of loop of Henle. Very simple. Let's take the heading ascending limb of loop of Henle. Concentrate here, guys. Now the urine is going through the ascending limb of loop of Henle. But concentrate in the ascending limb of loop of Henle. When the urine is going up, who is getting reabsorbed? See, sodium, potassium, chloride, some ions are getting reabsorbed. Means from the urine you are taking out the solutes. You are removing the solutes. So when you remove the solutes out of the urine will become diluted. So that's why as the urine is going through the ascending limb of loop of Henle, gradually see the urine is kept on getting diluted. Okay. So descending limb is a concentrating segment, but the ascending limb is diluting segment. Descending limb is permeable to water. See, descending limb is permeable to water, but the ascending limb is permeable to solutes. So we are removing the solutes, guys. Now, what is the name of this transporter? Okay, what is the name of this transporter which is helping in the solute reabsorption? The name of this transporter is called as NKCC. Okay, so that transporter which is helping in the reabsorption of sodium, potassium and 2 chloride ions, this transporter name is called as NKCC, that is sodium, potassium, 2 chloride ions, NKCC transporter. Okay, now if I am the examiner, the question that I will ask is NKCC transporter, okay, this transporter, NKCC transporter, where is it located? Is it located in the Bowen's capsule, PCT, DCT, loop of Henle, ascending limb, descending limb, something like that? Okay, so now tell me that NKCC transporter is presenting thick ascending limb of loop of Henle, thick ascending limb of loop of Henle. Next up, see in your pharmacology second year, you will study there is a drug which can block this NKCC transporter. Okay, there is a drug which can block this NKCC transporter. Okay, NKCC transporter. What is the name of the drug? The drug which is blocking the NKCC transporter is loop diuretics. Okay, so loop diuretics are the drugs which block the NKCC transporter. Done. Next, what else you should know? Concentrate here. Whatever the sodium that is coming into the cell, the sodium is going out into the medulla, and whatever the chloride that is coming into the cell, with the help of some chloride channels, the chloride is also going to the medulla. So sodium is going into the medulla, chloride is going to the medulla. But what is the problem here? The problem is with the potassium. See, potassium, whatever the potassium that is coming into the cell, it is not going into the medulla. And with the help of the sodium potassium pump, see, you all know this is the sodium potassium pump which is trying to throw 3 sodium ions out of the cell and trying to bring the 2 potassium ions into the cell. Now, even the sodium potassium pumps are also bringing the potassium ion into the cell. So, finally tell me, which ion is having problem? It's a potassium. The intracellular potassium levels are going to rise so much. There's lots and lots of potassium that's getting built up within the cell. Now, what you have to do with this potassium? Okay, because too much accumulation of potassium into the cell is also not good. If there is too much accumulation of potassium in the cell, the sodium potassium pumps won't work. It's not good. So again this potassium will be secreted back into the urine. So these epithelial cells, what they will do? They will secrete the potassium back into the urine. Okay, they are always continuously secreting the potassium. So that is what I am showing you here. Look guys, so here is the epithelial cell. Now in this epithelial cells, which ion concentration increases? It's the potassium concentration is building up. So where this potassium is going? The potassium is going back into the urine. So potassium is getting secreted 24/7. These TAL cells, thick ascending limb of loop of Henle epithelial cells are secreting the potassium. Now you tell me, potassium is which charge guys? Potassium is a positive charge. So because of this, the ascending limb of loop of Henle is having a positive luminal charge, positive luminal potential. So now look at this. Already I have told you that the thick ascending limb is a diluting segment. You already know. Next, it's only permeable to solutes, not to water. Okay. Next, the thick ascending limb of loop of Henle, see, ascending limb of loop of Henle has which potential? Positive luminal potential. Okay, positive luminal potential due to which secretion? Potassium secretion. What is the importance? The importance is, now my question to you, see, these positive charges like calcium and magnesium, these are divalent cations, right? Ca2+, Mg2+, they are highly positive charges. Now, do you think these positive charges can go through the TL easily? Can they go through the thick ascending limb easily? No, because already here positive charge is there. This positive charge will cause a repelling, okay, repulsion. So the positive charge of the ascending limb of loop of Henle doesn't allow the calcium and magnesium to go through TAL easily. So it forces the calcium, this positive charge forces the calcium and magnesium to be reabsorbed in the TAL. Okay. So what is the importance of this positive charge? The positive charge, the positive luminal potential helps in absorption of calcium and magnesium via the paracellular route. Paracellular route means in between the cells. So in between the cells, the calcium and magnesium will escape into the medulla. Okay. So done. Now with this successfully what we have completed the descending limb of loop of Henle and ascending limb of loop of Henle. Now let's see some clinical integration. Okay, pharma integration and medicine integration. What you need to know, guys, you first tell me, if I block this transporter, okay, do you think potassium is coming into the cell? No, potassium is not coming into the cell. Number 1, potassium not coming. Next, again, if I block this transporter, do you think sodium is coming into the cell? No. When sodium is not coming into the cell, do you think sodium will go out? No. When sodium is not going out, do you think potassium can come through the sodium potassium pump? No. So reason number 2. So what I am trying to say, if you block this NKCC transporter, sodium potassium 2 chloride importer, what will happen? First of all, potassium is not coming into the cell, and with the help of sodium potassium pump also, potassium is not coming into the cell. So what happens if the intracellular potassium levels decreases? So now intracellular potassium levels are decreasing. So automatically the potassium secretion will also decrease. Simple logic, no? So what I am trying to say, if you block this transporter, the potassium secretion will decrease. The potassium secretion will decrease. So now you tell me, drugs like loop diuretics, what they will do? They will block the NKCC transporter. They are blocking the NKCC transporter. When the NKCC transporter is blocked, the potassium secretion decreases. When the potassium secretion decreases, the positive charge will be automatically gone. Now there is no more positive charge. Now without this positive charge, what will happen? The calcium and magnesium will start to excrete in the urine. So calcium and magnesium reabsorption decreases. So it's a positive charge which is helping in the absorption of calcium and magnesium. Without that positive charge, the calcium and magnesium will be lost in the urine. Okay, this is the important point which I want you to know. So what are the examples of loop diuretics? Furosemide, torsemide. Now in your first year, I want you to understand. See, what is the meaning of the word diuretic? Okay, tell me, what is the meaning of the word diuretic? Diuretic means the one which increases the urination. Diuretics are the drugs which increases urination. Okay, they increases the urination or urine production. Okay, urine volume, they will increase. How? You think logically and tell me. Guys, here I am blocking this transporter. When I block this transporter, you tell me, sodium is going into the cell? No. Chloride is going into the cell? No. Sodium chloride not going into the cell. So where the sodium chloride will go? Sodium chloride lost in the urine. More and more sodium chloride lost in the urine, more and more water will follow. More and more water will follow. More the sodium chloride loss, more the water loss. Okay, simple. So if you are losing the sodium out of the body, automatically what will happen to your blood volume? Decreases. Simple logic. If you are losing the sodium out of the body, water will follow the sodium. So what happens to your blood volume? Decreases. Your blood pressure decreases. Okay, if you have edema, you can decrease it. So now tell me, where we use the loop diuretics? Imagine a person is having excessive fluid accumulation in his body. That is edema. Let's say pulmonary edema. Imagine a person with a pulmonary edema. There is a lot of excessive fluid accumulation in the body. How can you decrease the body fluids? How can you treat this edema? Give loop diuretics. Loop diuretics causes sodium loss, chloride loss. So along with that, water loss. So now the excessive fluids that are built up in your body will be removed out. So loop diuretics removes excessive water out of the body, increase more urine production. Done. And what is the side effect of the loop diuretic? Just now I have told you. The side effect of the loop diuretic, when you use this loop diuretics, the potassium secretion gone, the positive charge of the TAL will be gone. So calcium loss, magnesium loss. So highlight here, loop diuretics loop out the calcium. Means loop diuretics causes the calcium loss out of the body, magnesium loss out of the body, but mainly calcium loss. So loop diuretics causes calcium loss. So now you tell me, where the calcium is going? So now this excessive calcium, because of the loop diuretics, there is this calcium going into the urine, more and more calcium going into the urine. Now this calcium in the urine, it can lead to stone formation. So yes, loop diuretics causes kidney stones, true. Loop diuretics can cause kidney stones on long run because it's causing the calcium excretion. Calcium will build up in the urine and precipitate and forms the stones, kidney stones. Next up. Now, where else we can use this loop diuretics? See, loop diuretics will decrease our calcium levels. So they can be used in the treatment of hypercalcemia. If your calcium level is so high, as a doctor I have to decrease the calcium levels. How can I decrease your blood calcium levels? By using loop diuretics, because loop diuretics loop out the calcium, loses the calcium. Done. Next, already you know this, loop diuretics block which transporter? NKCC. NKCC. Next, what if the same NKCC transporter, the same transporter is mutated from the birth itself? Now it's not blocked, it's mutated, means it's not functioning from the birth itself. Then it is going to cause a disease called as Barter syndrome. So what I'm trying to say, it's the same transporter. Okay, it's the same transporter, but different conditions. See, loop diuretics block NKCC transporter. But in a condition called as Barter syndrome, the same transporter is affected. So can I say something like this? In both the condition, it's the same transporter that is getting affected. So there will be same clinical features. So Barter syndrome, it resembles which diuretic usage? Loop diuretic usage, because in both the conditions, it's the same transporter getting affected. So that's why, right? Barter syndrome, one by one point. Okay, Barter syndrome is the autosomal recessive disorder. Okay, which defect? TAL, thick ascending limb of loop of Henle defect. Okay, which transporter defect? NKCC transporter mutation, which is there from the birth. So usually Barter is from the birth itself. We call it as a neonatal Barter. It's seen from the childhood itself. Okay, Barter. Okay, next, this Barter syndrome resembles loop diuretic usage. Loop diuretic usage. Okay, no? Loop diuretic usage. because same transport that is getting affected. Now, in Barter syndrome, you tell me, the NKCC transporter is not working. So, sodium loss, chloride loss. So, in this baby, Barter baby, there is sodium chloride loss. Okay, there is sodium chloride loss. Now, because of the sodium chloride loss, there will be sodium loss, chloride loss, and water loss. Okay, there will be osmotic diuresis. There will be dehydration. Okay, dehydration is because of the polyuria, sodium loss, chloride loss, polyuria leading to dehydration. Now, because of this dehydration, when the baby is getting dehydrated, so most of the time the baby will be hypotensive because the fluid loss, sodium loss. So, the baby will have hypotension. Okay. Now, you tell me, what happened to the sodium levels in this baby? The sodium levels in this baby is going to be less. Chloride levels is going to be less because sodium chloride loss. So, now there is no sodium in the body. And what about the BP? BP also less. Now, you tell me, whenever there is a hypotension and a hyponatremia, that is a stimulus for the activation of which pathway? Whenever the baby is having hypotension and whenever the sodium levels are not appropriate, whenever there is a sodium deficiency, the RAS pathway will be activated. There is activation of RAS because I have told you, for the activation of RAS, it is the hypotension which is the stimulus as well as the hyponatremia is the stimulus. So, now RAS activated. Now, what this RAS pathway will do? RAS pathway helps in the production of aldosterone. Okay, RAS pathway helps in the production of aldosterone. So, why aldosterone? Because aldosterone can maintain the sodium levels. So, aldosterone, you know, 3 functions. Aldosterone will do 3 functions. Now, right now, aldosterone is there. But do you think the sodium levels can be elevated? No, because there is an intrinsic kidney defect, right? That NKCC transporter is affected. So, even though aldosterone will try to reabsorb sodium, aldosterone will try to maintain the sodium levels, but the sodium levels will be still less. Okay? Sodium levels still less because of there is intrinsic kidney defect. Okay, don't confuse. Usually students will think, sir, aldosterone is there, so sodium levels should increase. No, aldosterone is there. Aldosterone is trying to increase the sodium, but sodium levels will not go up because there is an intrinsic defect in the kidney. So, for most of the time, the sodium levels will be less. Sodium levels will be less, or in some conditions may be normal because of this aldosterone, but most of the conditions sodium levels will be less. But because of this aldosterone, what happened to the potassium and acids? See, we all know aldosterone, what it will do? It causes potassium and acid excretion. So, potassium is going out of the body. Potassium levels will decrease. Acid levels will decrease, leading to, right, leading to hypokalemic alkalosis. Okay, hypokalemic alkalosis. Now, because of this aldosterone, there is potassium loss as well as acid loss, hypokalemic alkalosis. So, now tell me, what are the clinical features of the Barter syndrome? See, the Barter syndrome clinical features, the baby is going to be dehydrated. Okay, sodium loss, chloride loss, water loss, hypotension with the hypokalemic alkalosis. Okay, why the sodium levels are not rising? Because there is a defect. Okay, NKCC is a transporter defect. So, sodium is kept on losing. Okay, done. So, again repeating, Barter syndrome, sodium loss, chloride loss, RAS activation, hypotension will be there, severe dehydration with hypokalemic alkalosis. Next step, what else you have to know? Guys, in this condition, as NKCC transporter is affected, now what will happen to the calcium? There is increased calcium excretion. Increased calcium excretion. Why increased calcium excretion? Because loop diuretics, Barter syndrome resembles which diuretic usage? Loop diuretic usage. Okay, in Barter syndrome, there will be NKCC transporter defect. NKCC transporter is not working. So, what will happen to the potassium excretion? Decreases. So, positive charge gone. So, calcium excretion. So, in loop diuretic usage, calcium loss. Barter syndrome also calcium loss because both syndromes are same. So, now increased calcium excretion. Where this calcium is going, guys? The calcium is going into the urine. So, in the urine, this calcium, now there is lots and lots of calcium in the urine. So, this calcium will form kidney stones. Kidney stones. Yes, Barter baby can have kidney stones. Now, without calcium, as the baby is losing the calcium, do you think the baby's bones will be strong? No. So, calcium deficiency from the childhood will lead to rickets. The baby can have rickets. This is called as a renal rickets because of the kidney problem. There is rickets. Renal rickets can be seen. Okay. Not only that, these patients, NKCC transporter defect, right? See this NKCC transporter, right, which is defective. The same NKCC transporter is also present in the ear. So, now NKCC transporter is present in the kidneys as well as the ear, guys. So, now when this NKCC transporter, when this chloride channel which is present in the ear, when it is defective, that can lead to deafness. So, these Barter babies can also have this sensory neural hearing loss. So Barter babies, remember, they are deaf babies. Okay, kidney stones, that is lots and lots of calcium is going. So there is calciuria. The word is important. Calciuria is seen in. Okay, there is hypercalciuria. Lots and lots of calcium is going in the urine. Calciuria is seen in the Barters. Kidney stones is there. Renal rickets is there. Sensory neural hearing loss is there. Okay, so this baby is so much dehydrated. The baby is severely dehydrated. If you do the physical examination, okay, there will be sunken anterior fontanelle. Okay, there is sunken anterior fontanelle, guys. Means the anterior fontanelle, because of the severe dehydration, it is sunken, indication of dehydration. So these are the important points which I want you to know regarding water. At least one thing, Barter is a defect in TAL, defect in NKCC transporter, resembles loop diuretic usage. What are the clinical features? Hypotension with hypokalemic alkalosis, said 10 times. Okay, that much important. Hypotension with hypokalemic alkalosis. Okay, visual deafness is there, renal rickets is there, kidney stones, hypercalciuria, RAS activation is there. So sodium loss, chloride loss, potassium loss, acid loss, calcium loss, everything loss. Okay, so with this successfully, what we have completed is Barter syndrome. In the next video, we'll be starting with the distal convoluted tubule and the clinical disorders related to it. Hope the video is helpful. Thank you.